Okay, let's unpack this. You know that feeling, right? Spring pops up, or maybe you're just having some time with your furry friend, and bam, your eyes turn into these itchy, leaky messes. Feels like the itch is right behind your eyeballs sometimes.
Oh yeah, that's a pretty common experience.
Exactly. And today, we're diving deep into what's actually causing that irritation. Allergic conjunctivitis.
That's right. And think of this not just as a chat about itchy eyes, but more like your personal streamlined guide.
Mm,
We've waded through the detailed notes, and our mission here is really to pull out the absolute must-know facts for you.
perfect.
So whether you're revising for something like the MSRA or you just genuinely want to understand what's going on with your own eyes, perhaps, we're aiming to make it clear, memorable, and, well, hopefully easier than reading dense text.
Exactly. Cutting through the noise, getting you those high-yield facts. So let's just jump straight in. What is allergic conjunctivitis exactly?
Okay, so in simple terms, it's an inflammation, specifically inflammation of the conjunctiva.
Right, the conjunctiva.
Yeah.
Remind us what that is.
Yeah, it's that thin, sort of transparent layer. It covers the white part of your eye, the sclera, and also lines the inside of your eyelids. Think of it like the eye's delicate inner skin, almost.
Got it. So that layer gets inflamed,
Mm-hmm.
and the name gives it away. It's triggered by an allergic reaction.
Precisely. It's your immune system going a bit overboard, reacting to substances that are normally, well, harmless.
Like what sort of things?
Oh, the usual suspects, really.
Hmm.
Pollen is a big one, especially seasonally, spring and summer. Pet dander, dust mites, those tiny things living in our homes. Sometimes even things like certain eye drops or makeup can set it off.
And the main symptoms are that inflammation and the itch.
The itch, yes, that relentless itch is key. And inflammation, so redness, swelling. It's also very closely linked with hay fever. Often, if you suffer from hay fever, your eyes might flare up too.
Okay, definition clear. But why does this happen? What's the body actually doing wrong, so to speak? What's the etiology?
It really boils down to an immune system that's, let's say, overly sensitive or hyperresponsive. So when you come into contact with these allergens, pollen, dander, whatever it is for you, your body's defense mechanism mistakenly flags them as dangerous invaders.
Even though they're not actually harmful.
Exactly. And this kicks off a whole cascade, a chain reaction.
And what are the main chemical messengers involved in that reaction?
Histamine is the big one everyone knows about. But there are other inflammatory chemicals released too. The immune system basically dumps these chemicals into the conjunctiva in response to the allergen.
And those chemicals cause the symptoms we feel.
That's right. They cause the blood vessels to dilate, hence the redness. They irritate nerve endings, causing that awful itch, and they contribute to the swelling and watering.
Right. It makes sense now why histamine is such a focus for treatment. So it's like the body's security system hitting the panic button unnecessarily. Now, who's more likely to get this? Are there particular risk factors?
Yes, definitely. A really significant factor is your personal history or even your family's history of allergies. If allergies like hay fever or eczema run in the family, or if you have them yourself, you're automatically at higher risk.
Okay.
And there's a very strong link with something called atopy.
Atopy. Can you break that down a bit?
Sure. Atopy is basically a genetic tendency to develop allergic diseases. So we're talking conditions like atopic dermatitis, that's eczema, asthma, and allergic rhinitis, which is hay fever. People with this underlying predisposition are just more susceptible.
Okay, that clarifies the link. And I guess the most straightforward risk factor is just being around the things you're allergic to.
Absolutely. Simple exposure,
Right.
high pollen counts, spending time indoors with a cat if you're allergic, living in a dusty environment.
Yeah.
It all increases your risk. And like we said, it often clusters. So having allergic rhinitis or asthma makes you more prone to the eye symptoms, too. They often go hand in hand.
Right, it's all interconnected in that allergic picture.
Mm.
Okay, let's zoom in even closer now. What's happening at the microscopic level? The pathophysiology.
Okay, this is where it gets quite specific. It involves antibodies called immunoglobulin E, or IgE.
IgE.
Yeah. Think of these IgE antibodies as little tailored alarm bells. They sit on the surface of specific cells in your conjunctiva called mast cells.
Mast cells, okay.
So when an allergen, you're sensitized to, let's say, a specific type of pollen enters your eye, it finds and binds to these specific IgE alarm bells on the mast cells.
And that binding is the trigger. That's the O moment for the cell.
Precisely. That binding event signals the mast cell to, well, degranulate, which basically means it rapidly releases its contents.
Which includes histamine.
Histamine, yes, and a whole cocktail of other pro-inflammatory mediators. And these substances are what directly cause the effects we see and feel. The blood vessels dilate, making the eye red, fluid leaks out, causing swelling, nerve endings get stimulated, causing that intense itch.
That itch again. Knowing about histamine in mast cells really helps understand why it's so bad.
Okay, but crucial question now. What if it isn't allergies? Red, uncomfortable eyes could be other things. What's the differential diagnosis we need to consider? This is super important, right?
Absolutely critical. You cannot just assume every red eye is allergic conjunctivitis.
Oh.
There are several other possibilities, some much more serious.
Like what?
Well, a really common one is infective conjunctivitis. Could be viral, could be bacterial, usually more sticky discharge with bacterial, more watery with a viral, but not always clear-cut.
Okay.
Then there's blepharitis. That's inflammation of the eyelid margins themselves, often looks crusty. Uveitis is inflammation inside the eye, often painful and associated with light sensitivity. Acute glaucoma involved a sudden rise in eye pressure, very painful, often with nausea and blurred vision. That's an emergency.
Definitely sounds like things you don't want to miss. Are there specific red flags that scream, not allergies? Yes. Significant pain is a big one. Allergic conjunctivitis is typically itchy, maybe some burning or grittiness, but usually not severely painful. If there's proper pain, especially if it's mainly in one eye, think about keratitis, inflammation of the cornea.
Keratitis. K for
So-
cornea?
K for cornea, yeah, and often K for knife-like pain, maybe? It often comes with photophobia, sensitivity to light, and a very injected red eye. Another one is scleritis, inflammation of the white part, the sclera itself. This causes a really severe, deep, boring kind of pain that can even spread to the forehead or jaw.
Ouch.
Then there's episcleritis, which is inflammation of the layer on top of the sclera. That's usually less painful, maybe just mild discomfort, often in just one sector of the eye, which looks quite red. Think E for episcleritis, E for external redness, less severe pain.
Those little memory aids are helpful. What else is on the list?
Let's see. Orbital cellulitis is serious infection around the eye socket, needs urgent treatment. A foreign body, obviously something actually in the eye.
Yeah, that makes sense.
Then you've got infections like ocular herpes simplex or herpes zoster ophthalmicus shingles affecting the eye nerve. Also, non-infectious things like dry eye syndrome, which can cause gritty discomfort and redness, or maybe an inflamed growth on the eye surface, like a pterygium or pinguecula. And finally, things related to exposure arc from welding, snow blindness, maybe even retinal burns, though the history usually makes those obvious.
Wow, okay, that is quite a list. So for anyone listening trying to figure things out, the key takeaway seems to be, is the main feature this intense itch, or is there significant pain, vision changes, a sticky discharge, or just one eye badly affected? Is it just itchy? Mental check is probably a good first step.
Exactly. That's a very good starting point. Pain, marked vision loss, photophobia, discharge that's not just watery, those should raise concern. It's something else.
Okay, let's shift gears. How common is this allergic conjunctivitis, particularly here in the UK? What's the epidemiology?
Oh, it's incredibly common, really widespread, especially as you'd expect during the main allergy seasons, spring and summer.
Who gets it most?
It affects all ages, definitely, but we do tend to see it more often in children and younger adults. The prevalence figures are actually quite startling. Some estimates suggest up to 40% of the population might experience it at some point.
40%, wow.
Yeah, it's huge, and probably underdiagnosed too, as many people might just put up with mild symptoms or assume it's just tired eyes. And as we said, it's strongly seasonal for many, peaking when pollen counts soul.
And that link with hay fever, allergic rhinitis.
A very strong link. Studies show a big overlap, somewhere between 30% and maybe even up to 70% of people with allergic conjunctivitis also have allergic rhinitis symptoms, like sneezing and runny nose. Finding both really points strongly towards allergy.
Makes sense.
And just briefly, there are more severe chronic forms like vernal keratoconjunctivitis, which have specific geographical patterns sometimes. And interestingly, there does seem to be a trend. Over the last few decades, the prevalence of allergic conditions generally, including conjunctivitis, seems to be rising.
Really? Any idea why?
The exact cause isn't definitively known. It's likely multifactorial, maybe changes in environment, lifestyle. The hygiene hypothesis, maybe just better diagnosis and awareness. It's an area of ongoing research.
Interesting. Something to watch. Okay,
Okay.
so if someone walks into clinic, what are the classic things they'll complain about? What's a typical clinical presentation?
The absolute number one, the hallmark symptom, is the itch. It's often described as intense, sometimes unbearable, You really have to ask about the itch specifically.
Okay, itch first. What else?
Alongside that, you'll usually see redness. The eyes look bloodshot. There's often watering, excessive tearing. The eyelids might look puffy or swollen. Patients might also mention a gritty feeling, like there's sand in the eye, or maybe a burning sensation. Sometimes light sensitivity photophobia too, though usually mild compared to, say, keratitis.
One eye or both?
Usually both eyes are affected, though one might feel a bit worse than the other sometimes. And the symptoms can fluctuate. They might come and go with exposure or be more persistent if it's a year-round allergen like dust mites.
So key features on history are bilateral symptoms, that prominent itch, and maybe a personal or family history of atopy we talked about.
Exactly. Those three things together are highly suggestive. And the timing gives clues too. Worse in spring-summer points to seasonal pollen allergies. Constant symptoms suggest perennial allergens like house dust mites or pets.
And what might you actually see when you examine their eyes?
You'll see the redness, obviously what we call conjunctival injection or hyperemia. You'll typically see watery discharge, clear, not thick or pus-like in bacterial infection. There might be eyelid swelling or edema. The conjunctiva itself might look a bit swollen or boggy. That's called chemosis. And sometimes, particularly in more chronic cases or specific types, you might see little bumps under the eyelids called papillae.
Papillae, okay.
And in cases of contact dermatoconjunctivitis allergy to something touching the eye area like makeup or drops, you might also see redness or eczema-like changes on the skin of the eyelids themselves.
And you mentioned something specific for contact lens wearers earlier.
Ah, yes, good point. Contact lens wearers can develop a specific type called giant papillary conjunctivitis, or GPC. They often get significant chemosis, those large papillae bigger than 1 millimeter under the upper eyelid, and sometimes a stringy mucus discharge. So if a lens wearer comes in with itchy, uncomfortable eyes and mucus, definitely think about GPC.
Got it. Very important for lens wearers. Okay, so someone presents with these classic symptoms. The story fits. How is the diagnosis usually confirmed? What investigations are needed?
Well, the good news is, for the vast majority of cases, the diagnosis is clinical.
Meaning based on the symptoms and history.
Exactly. Based on that characteristic story, the itching, redness, watering, the timing, the personal or family history of allergies, you can usually be pretty confident about the diagnosis without needing lots of tests. It's about pattern recognition.
So not everyone needs swabs or allergy tests.
No, definitely not routinely. However, if the diagnosis isn't clear-cut, if the symptoms are unusually severe, if it's not responding to the usual first-line treatments, or if you suspect one of those other conditions we talked about, then specific tests might be warranted.
What would a basic eye check involve then?
A standard assessment would include checking their visual acuity, making sure their vision isn't significantly affected. Looking at the eyes with good lighting, maybe using a slit lamp if available in primary care or definitely in ophthalmology, to examine the conjunctiva, cornea, and eyelids closely. Sometimes fluorescein staining might be used. That's a yellow dye to check for any scratches or ulcers on the cornea, especially if keratitis is suspected, but it's often normal in simple allergic conjunctivitis.
And if you're still unsure after that?
If doubt remains, you might consider things like conjunctival swabs, mainly to rule out infection, although their yield can be low. If identifying the specific allergen is important perhaps for targeted avoidance advice or considering immunotherapy down the line, then allergy testing comes in.
Like skin prick tests.
Skin prick testing is common, yes. Or blood tests looking for specific IgE antibodies to common allergens, sometimes called RASI tests, though that's an older term. Total IgE level in the blood can also be checked, though it's not very specific. Remembering the different types, seasonal, perennial, GPC, contact, helps guide whether testing is likely to be useful. And again, vernal and atopic keratoconjunctivitis are kind of separate categories, often needing more specialist investigation.
Right, so clinical diagnosis first, tests reserved for trickier situations. Okay, the crucial part, what can actually be done about it? How do we manage allergic conjunctivitis, say, following UK guidelines?
The main aims are pretty straightforward. Relieve the symptoms, make the person comfortable, and reduce that underlying inflammation.
And how do we achieve that?
It's usually a combination approach. Firstly, trying to avoid the known or suspected allergens is key, although not always easy. Then, using simple measures like cool compresses for soothing, lubricating eye drops can help flush things out and soothe, and then, of course, medications. Sometimes, if it's severe or persistent, specialist input is needed.
Let's talk about the non-drug advice first.
Yeah.
What practical things can people do?
Number one, and it's so hard but so important, Resist the urge to rub your eyes.
Easier said than done when they itch like crazy.
No, but rubbing really does make it worse. It releases more histamine from those mast cells and can just perpetuate the cycle. Plus, you risk scratching your eye or introducing infection. So really try not to rub.
Okay, noted. What else?
Applying cool compresses like a clean flannel soaked in cool water held gently over closed eyelids for a few minutes several times a day can be incredibly soothing. Using artificial tears, those lubricating eye drops, frequently throughout the day is also great. They help dilute and wash away allergens sitting on the eye surface, and they provide moisture and comfort.
What about contact lenses?
Generally, it's best to avoid wearing contact lenses during a flare-up if possible. Allergens and inflammatory mediators can get trapped under the lens. If you absolutely need to wear them, switching to daily disposable lenses is often recommended, as you start with a fresh, clean lens each day, minimizing allergen buildup. And fundamentally trying to identify your triggers. Is it pollen, the cat, dust? And then minimizing exposure is the most effective long-term strategy. For mild symptoms, just artificial tears might be enough.
Practical tips. Now for the medications. What are the main pharmaceutical options?
Right. First-line treatment is usually a topical medication, eye drops. The most common are topical antihistamines.
Drops with antihistamine in them.
Exactly. They work directly where the problem is, blocking histamine receptors on the conjunctiva, and they provide pretty rapid relief from itching and redness. Often they're combined with a mast cell stabilizer in the same drop.
Mast cell stabilizers. You mentioned those earlier.
Yes, drugs like sodium cromoglicate or nudocremil, they work by preventing the mast cells from releasing histamine and other chemicals in the first place. They're better for prevention than immediate relief, though, as they can take a few days or even weeks to reach full effect. So, often used regularly through an allergy season, sometimes alongside an antihistamine for breakthrough symptoms.
So topical antihistamines, maybe with mast cell stabilizers. What else?
There are also combination drops that have an antihistamine plus a decongestant of vasoconstrictor, which shrinks the blood vessels to reduce redness quickly. They look good cosmetically, but they're generally not advised for long-term use, as you can get rebound redness when you stop them. Sometimes a topical NSAID drop, like diclofenac or ketorolac, might be used for symptom relief, particularly if there's discomfort.
What about tablets? Oral antihistamines.
Oral antihistamines can be useful, especially if the person also has other allergy symptoms like hay fever. They can help with the eye itch, too. The main consideration there is potential drowsiness with some of the older first-generation ones, which can be an issue for driving or working. The newer ones are generally non-sedating or less sedating.
Okay. And the big one, steroid eye drops.
Topical corticosteroids. Yes, they are very effective at calming down severe inflammation when other treatments aren't enough. However, and this is a really important point, they come with potential side effects, like raising eye pressure, causing cataracts, or increasing infection risk. Because of this, they should only ever be prescribed and monitored by an ophthalmologist, an eye specialist.
So never started in primary care.
Absolutely not. If you think someone needs steroid drops for allergic conjunctivitis, that's a definite trigger for referral to ophthalmology. It's really crucial.
Okay, crystal clear on the steroid point.
Yeah.
So besides needing steroids, when else should someone be referred to a specialist? What are the referral criteria?
Well, any urgent red flags we discussed earlier, sudden vision loss, severe pain, suspicion of keratitis, uveitis, glaucoma that needs an immediate same-day referral. If the diagnosis is genuinely uncertain after initial assessment, it's wise to discuss with or refer to ophthalmology. If the symptoms are severe and persistent despite trying the standard first and second line treatments, referral is appropriate. And also, referral to an allergy specialist might be considered if the eye symptoms are part of a wider multisystem allergic disease or if it's having a really significant impact on their quality of life.
Okay, so manage straightforward cases, but have a low threshold for involving specialists if things are severe, uncertain, or not responding.
Got it.
Now, looking ahead, what's the long-term outlook? What's the prognosis like for people with allergic conjunctivitis?
Overall, it's often a chronic condition, meaning it can linger or recur over years, and how it behaves can vary a lot from person to person.
But can it be controlled?
Yes, that's the good news. For most people, the vast majority, symptoms can be controlled effectively with the strategies we've discussed, avoiding triggers where possible, using medications as needed, and importantly, vision is usually well maintained.
Does the prognosis differ for those specific types you mentioned?
It can do, yes. For the common seasonal and perennial types, the prognosis is generally very good in terms of vigor. Symptoms respond well to treatment, but flare-ups are common, especially during high pollen seasons or with allergen exposure. Vernal keratoconjunctivitis, that more severe type often seen in younger people, typically improves or resolves after puberty, which is good. However, it does carry a definite risk of corneal complications, like shield ulcers, which can potentially affect vision if not managed properly by an ophthalmologist.
And the atopic type.
Atopic keratoconjunctivitis, often seen in adults with severe eczema, is generally a more challenging chronic condition. Unfortunately, it has a higher risk of potentially sight-threatening corneal problems like scarring, thinning, or vascularization. These patients really need ongoing specialist care.
So, while the common itchy eyes are usually okay long-term, those specific vernal and atopic types need closer monitoring.
Okay. Are there any significant downsides or complications from allergic conjunctivitis itself, assuming it's the more common type?
Generally speaking, simple allergic conjunctivitis doesn't usually cause serious lasting problems on its own. The main risk, as we keep saying, comes from rubbing.
Back to the rubbing again.
Yes. Vigorous rubbing can potentially lead to corneal abrasion scratches on the surface of the eye. It could theoretically even contribute to a condition called keratoconus in susceptible individuals over the very long term, though that's more complex. And rubbing can introduce bacteria, leading to a secondary infection.
Okay.
Chronic long-term low-grade inflammation could potentially contribute to other minor eye surface issues. But with prompt treatment when symptoms flare up, the risk of significant complications is generally low. Severe things like corneal ulceration are really quite rare and usually only seen in the context of those very severe types like vernal or atopic, or if there's a secondary infection. Okay, that's reassuring for most people. So let's try and boil this all down. What are the absolute key takeaways from our deep dive today, especially for someone maybe revising this for MSRA or just wanting the core facts?
Okay, key takeaways. 1, it's inflammation of the conjunctiva triggered by an allergic reaction. 2, the hallmark symptom is ITCing. Bilateral redness and watering are also common. 3, it's caused by the immune system overreacting, releasing histamine and other mediators from mast cells after allergen exposure, pollen, dander, dust mites, etc. 4, crucially, differentiate it from other red eye causes. Look out for significant pain, vision loss, photophobia, purulent discharge, or unilateral signs. 5, it's very common, often seasonal, strongly linked to other atopic conditions like hay fever and eczema. 6, management centers on allergen avoidance, cool compresses, artificial tears, and topical medications, primarily antihistamines and mast cell stabilizers. 7, topical steroids are effective for severe cases. The T must only be initiated and monitored by ophthalmology due to risks. That's a key referral point. 8, prognosis is generally good for common types, but vernal and atopic keratoconjunctivitis require specialist management due to corneal complication risks.
Excellent summary. That really covers the essentials. Maybe a quick memory tip based on that.
Let's try. Think ITCH, intense tearing, gymosis, hyperemia. And for management, avoidance, artificial tears, antihistamines, mast cell stabilizers, and refer if red flags, pain, poor vision, puckos, or if steroids seem needed.
Nice. ITCH, AAA, and RRS. Helpful. Okay, final thought then. Maybe for everyone listening, think about your own allergies if you have them. Knowing what we've discussed, this mechanism, what maybe one small change could you realistically make in your environment or routine to try and minimize exposure to whatever triggers your itchy eyes?
That's a really practical takeaway. And for those of you who are deep in MSRA preparation and looking for more focused resources, definitely check out pathomsra.com. They've got loads of useful materials.
Absolutely. And if you're after even more great learning stuff, particularly free resources to help with MSRA prep, then head over to freemsra.com. Thanks for diving deep with us today on allergic conjunctivitis.